Hi guys, this is Dr. Burns, and today's lecture is going to be over pathophysiology of gait in persons with neuromuscular dysfunction. This is going to be longer than my typical lecture would be with you guys. And while it's not my preferred format to be lecturing you guys over a longer period of time, this lecture lends itself to that format just fine. I want to thank Dr. Greg Brasola for his slides. I have adapted them with his permission and I'm using them to be able to lecture to you guys today. So without further ado, here are objectives. Today we want to discuss and examine the principles of pathologic gait, discuss the influence of body structure and function on the gait cycle, review various methods of gait assessment and analysis, and finally discuss common gait impairments and deviations for various clinical presentations. So I want you guys to just take a look at this video real quick and do just a preliminary gait analysis. Just see what you see what you can come up with. However you currently do your gait analysis. Alright, so we'll put a pin in that and we will come back to that later. Because now we're going to talk about just what is walking. So walking, it's convenient, helps us get from one place to another over short distances. And in its normal form, it appears to be coordinated, efficient, and effortless. But we're going to look how different pathologies disrupt that, and we'll actually see how walking is a pretty complex process. So just some umbrella terms when it comes to being able to analyze gait. So we have reciprocal floor contact, and so one limb is in the support phase while the other limb is advancing to its new support site, and then they switch roles. And a single sequence of this is called a gait cycle. We can also look at the time and distance qualities. So your temporal and spatial measures, things like your step length, step width, cadence, all of those sorts of things when we are describing gait. This also encompasses terms such as like single limb, double limb, etc. And then finally we have your functional phases of gait, which include weight acceptance, single limb stance, and swing limb advancement, and the events that occur within them. And so we like to use the Ranchos Los Amigos terms to be able to break gait down even further into initial contact, loading response, mid-stance, terminal stance, pre-swing, initial swing, mid-swing, and terminal swing. So this figure represents all of the umbrella terms that we just talked about in terms of normal gait. In a nutshell, you have your reciprocal gait patterns, your right step, left step, right step, left step. You have your time and distance qualities represented by double limb support time, single limb support time on both the right and the left. This also encompasses about 62% of the gait cycle in single limb support versus 38% in double limb support. And then you also have your Rancho phases. Initial contact is cut off somewhere, but loading response through terminal swing here. And so you can think about your functional phases and how they fit into that. So weight acceptance fitting into initial contacts and loadings response. Single limb support fitting into mid stance, terminal stance, and then swing limb advancement starting out at pre-swing and then taking you through terminal swing. So what all can affect normal gait? So there's tons of variables that can come into play, but if we think about kind of internal mechanisms that can affect the way that somebody walks and cause their gait to be pathologic, we really have 5 categories. And these categories include abnormal joint range of motion or deformity, muscle weakness, sensory impairment, pain, and impaired motor control. So now all of these could be present within the same person, or it may just be one thing going on, two things. Any combination can impair somebody's gait ability. And so your job with gait analysis is to kind of see where the issues are happening in their gait and hypothesize, and then proceed to test which of these things could be contributing to their abnormal gait. So now we're going to look at each of these in isolation, starting with abnormal joint range of motion. So most often when we talk about abnormal joint range of motion, it tends to be limited. There are times when it is excessive, but especially in people with neurologic issues that we're working on gait, then limited range of motion tends to be more common than excessive range of motion. So a term that you might hear when it comes to limited range of motion is contractures. Contractures are common, and they represent structural changes that happen within the connective tissue of the muscles, ligaments, or the joint capsule that causes limited range of motion. Contractures usually take place due to inactivity or injury, and we can usually tell that a contracture is there just by trying to move the joint through its normal range of motion. Generally, it should take about 2 finger strength to bring a joint through its full range of motion, and if it takes more than that, then we could say that there might be some kind of contracture there. And contractures come in 2 different forms. So we have rigid and elastic contractures. So let's talk about elastic first. So an elastic contracture will yield to a forceful stretch. And so if you're putting all your body weight into it, then that joint is still going to go through its range of motion. You might say that they're tight. But this is still going to affect the person's gait in certain parts of the gait cycle, because the muscles just aren't programmed to pull as hard as they would need to pull to be able to get that joint through its range of motion. And so this is contrasted with a rigid contracture, and that resists all your stretching efforts. At a certain point, the joint just doesn't go any further into the range of motion that you want to bring it. So as you can see in this chart, a normal joint should take minimal force to be able to bring through its full range of motion, and with a contracture, it's going to take much more force to be able to bring it through its range of motion. And their base of support is way in front of their center of mass. And so if this person doesn't compensate, this person is going to fall backwards because their center of mass is outside of their base of support. So now this person compensates in a pretty uncreative way. He just shifts his weight forward. And so this accomplishes the job of bringing his center of mass over his base of support, but now he doesn't have his whole foot on the ground. Now his heels are floated up because he doesn't have the dorsiflexion to be able to accommodate to a foot flat position, and so his heel just raises. So that has obvious implications for balance, because now we don't have nearly as big of a base of support as we did before. So this person decides to compensate differently. This person is using some slight trunk flexion with knee hyperextension to be able to help compensate for the lack of dorsiflexion here. And finally, our guy in picture D gives us a little bit more forward trunk lean while maintaining a relatively normal knee position. So now look at this in a more dynamic picture. We're going to look at what a 15-degree plantar flexion contracture's effect is on gait. And so, just a quick review. For normal range of motion at the ankle, at initial contact, the person's ankle is neutral. Then in loading response, we shift into 5 degrees of plantar flexion. And then in mid-stance, we're shifting into 5 degrees of dorsiflexion, 10 degrees of dorsiflexion in terminal stance. If the person has an elastic deformity or elastic contracture, when they're in the stance phase, then we might see that they have enough force to be able to have their joint yield. And so They may look normal during gait, or their ankle motion might just be slightly delayed. But in swing, when they don't have all of that body weight coming down to try and help the joint go through its normal range of motion, that's where we're going to see potentially some more issues, because the pretibials aren't programmed to pull harder, and so we might see that this person with an elastic contracture has issues mostly with swing limb advancement. Then if we have a rigid deformity, if the joint just doesn't move at all no matter how much we push on it, then it's going to obstruct progression of the tibia over the ankle during stance phase, in addition to disrupting our swing phase. And so we're going to see with this person that has a rigid contracture that they're going to need potentially more compensations, especially during the stance phase. So we might see with this person that they have greater hip flexion during weight acceptance, so that way they are able to achieve a foot flat posture. So on this slide, we're going to take a look at this in action. So you can see with this person, he has an ankle contracture, and you can see that he has a shortened step length. He doesn't progress through any of the rockers at his ankle. He's plantar flexed throughout the whole gait cycle, obviously. His excessive extension throughout weight acceptance, single limb stance, and swing limb advancement at his knee. At the hip, he externally rotates during swing limb advancement and leans to his left at his trunk, both of those probably to try and clear the foot through. So now we'll see after his operation to lengthen his tendon, he has a much improved stance phase. Now he demonstrates a little bit of excessive knee flexion during swing limb advancement with decreased dorsiflexion at his ankle, probably due to weak pretibials, but we'd have to test that out to be sure. All right, so now we're going to look at knee flexion contractures and what their impact is on gait. And so for a quick review, the normal range of motion would be about 5 degrees at initial contact, and then we move into 5 degrees of flexion. Then we move into 15 degrees of flexion at loading response, back to 5 degrees of flexion as we progress through mid-stance to terminal stance. And then during pre-swing, we have a really quick knee flexion moment that brings us to 50 degrees. Then at initial swing, we're getting to 60 degrees. Mid-swing, we start to extend our knee to 25 degrees, and then finally at terminal swing, we're at 5 degrees, preparing for their next initial contact. And so with a hamstring contracture, we'll see during single limb stance that it increases the muscle demand on the quadriceps to be able to stabilize the flexed knee. And then it also blocks the progression during stance phase by inhibiting the advancement of the thigh over the tibia. Because our hamstring is so tight, our thigh is not able to pass back over our tibia and be able to get into that nice extension that we see in terminal stance. And so we don't have as much progression through single limb stance when we have a knee flexion contracture. So then if we look at the effect on swing limb advancement, we would see a shortened ipsilateral step length due to the lack of terminal knee extension. And so this affects us most during terminal swing. If the knee flexion contracture is greater than 5 degrees, then we're not going to get to that pre-positioning spot that we would need to for our weight acceptance. And so we'll see in altered initial contact due to the lack of that terminal knee extension. And so we're going to take a look at this. And so if you look at his weight acceptance, you'll see that he doesn't have initial contact, and he's excessively flexing at his knees, which is putting increased demand on his quads. During single limb stance, let me back it up some. You'll see that he continues to show excessive knee flexion throughout single limb stance. He's also kind of excessively flexed at his hip, and we're not seeing a terminal stance. So there's no real heel rise as the thigh passes over the tibia. And And then at the head, arms, and trunk, we're seeing a backwards trunk lean to be able to maintain his center of mass over his base of support. And we're also seeing decreased arm swing and trunk rotation. So now we'll look at a hip flexion contracture. So on the left, we can see that this guy is standing with his center of mass anterior to his base of support without compensation. His pelvis and his trunk are tilted forward, and if he doesn't compensate, then he will likely fall forward because his center of mass is over his base of support. So now if we move to the center, we see that this person is compensating through trunk hyperextension. And so having that much lordosis at the lumbar spine can bring your center of mass back, and your center of mass is now over your base of support. And then this is another way to compensate here. We see this crouched position where the knees are flexed as well as the hip. And now our center of mass is over our base of support. So now we'll look at the impact of this on gait. So a mild hip flexion contracture can be compensated for by lumbar lordosis. You saw in that last picture that if the hip flexion contracture is pretty severe, then we're probably not going to have enough spinal mobility to be able to allow for full compensation. Sometimes kids can be the exception to this rule because of how mobile their spine is, but in general, we'll see that if somebody has limited hip range of motion, then they may go more towards that crouched gait. So then breaking it down by our functional phases, if we look at the single limb stance, we'll see that the person will have reduced range of motion in terminal stance. So we'll see an early heel off if we get a heel off at all, as well as an early toe rocker, because we're not having our thigh be able to translate really far over our tibia. And so we're not going to get that true terminal stance. So then if we move into swing limb advancement, we'll have a reduced step length on the contralateral side, again, because we're not achieving that nice big terminal stance that we would need to be able to improve our contralateral step length. And then for weight acceptance, we might see a foot flat contact on the contralateral side because of that insufficient terminal stance on our reference limb. All right, so now we're going to take a look at this here, and the first thing you might see is surprise, no heel off for that terminal stance. You can see that on the contralateral limb, he has a decreased step length there. We're not able to achieve that nice terminal stance. Also has a foot flat contact bilaterally during weight acceptance. On his contralateral limb, that's likely due to that limited hip flexion. So these are all of your potential range of motion abnormalities that can happen in the lower extremity. Your most common range of motion deficiencies are going to be the ones that are highlighted. And so at the ankle, if range of motion is a problem, more often they're plantar flexed rather than showing excessive dorsiflexion. If range of motion at the knee is the problem, then we often will have a flexion contracture. And if range of motion at the hip is a problem, then we also have a flexion contracture as well. And so if you think about the posture that you usually sit in, then that may help explain why we see in our patients with a lot of neuro issues, why we might see those as some of the potential range of motion abnormalities that we see commonly. So now the concept of shank to vertical angle. So normal gait and posture is reliant on all of our body segments being properly aligned relative to the force of gravity. Now, gravity acts in a straight down vertical line that is perpendicular with the ground. And when I say shank, I am meaning our lower leg. And so our shank to vertical angle is what angle is our lower leg at, so our tibia, in relation to the true vertical. And so this can be described as being reclined. So our shank is reclined relative to true vertical, which kind of looks like it is angled backwards from a true vertical. And so you would see this like during loading response. We'll see that on our next slide. And then you can also describe it in terms of an incline, where it is forward relative to the line of gravity. And just like we'll see it on our next slide, you'll see that like in terminal stance. So now we get to see our shank to vertical angle in action. So during loading response, we're in a reclined angle. Our first rocker takes us from like initial contact into loading response. And so we see that our shank to vertical angle goes from being reclined to being less reclined. We start progressing through our second rocker, our ankle rocker, into mid stance. So we go from 10 degrees of recline into 10 degrees of incline. Then we transition to our third rocker, our forefoot rocker, where our tibia continues to incline further, and finally into our toe rocker, where our tibia is kind of maximally inclined there. So the other thing that I want to bring your attention to is over here in mid stance, because this is going to have important implications for orthotic and prosthetic management later on. You'll see that during mid stance, when you might think that everything is aligned with the force of gravity, and when I say everything, I mean the thigh and the shank, that's not the case. Rather, the shank is inclined about 10 to 12 degrees here. And so there's never a point during the gait cycle where both the thigh and the shank are directly aligned with vertical. But understanding that 10 to 12 degrees of incline during your mid stance is going to be important for orthotic and prosthetic management later on. Just put that under your hat for now. So good job making it to this point. Now may be a good time to pause the lecture and take a break. You can also use this time to review gait deviations resulting from insufficient or excessive range of motion before you move on to the next part of this lecture, which is muscle weakness. So muscle weakness is just the manifestation of too few motor units available to be able to generate forces to create motion or to resist ground reaction forces created during walking. So this can be caused by a number of different issues. It could be disuse atrophy, or it could be related to some kind of neurological impairment. It could be upper motor neuron processes or lower motor neuron processes. So when we're looking for upper motor neuron processes, we want to look for the associated signs. So those might be impaired motor control, increased tone or spasticity, hyperreflexia, and potentially sensory impairment. Versus lower motor neuron, we would see hypotonia. They might still have sensory impairment. We wouldn't expect spasticity with lower motor neuron. We can also look at the pattern of the person's weakness. Does this seem to be more of a peripheral nerve related issue? Do the onset and symptoms match a known pathology that we might be screening for? That might be the case for somebody with Guillain-Barré syndrome that comes to you telling you that they had ascending sensory loss bilaterally and then started to have motor weakness. And so those are all factors that you want to take into account. Now, if the person does have sensation and motor control intact, and we are just dealing with mild to moderate weakness, then they might be able to compensate by modifying the timing and their extent of their muscle contractions to prevent any kind of unstable postures or alignment. And so an example where you might see this practically is just an older person shortening their step length. So they still have intact motor control and sensation. They're able to feel where they're putting their joints and control all of their muscles individually. They just might not have enough power in their motor units to be able to create lever arms where their muscles are going to have to generate a lot of force to keep their joints stable. And so they can compensate by just decreasing the lever arms by shortening their step length. So, a quick quiz inside the lecture here. How do we measure muscle strength clinically? If you said manual muscle testing, then you would be correct. And then the next question is, how does manual muscle testing stack up when it comes to accurately being able to predict walking ability? So if somebody scores a 5 out of 5 on a manual muscle test, what percentage of power do you think the person has to generate compared with a non-paralytic normal person? The answer is 65%. And so the person only has to generate 65% maximal contraction to be able to score a 5 out of 5 on a manual muscle test for the hip extensors. What about the knee extensors? What do we think a 5 out of 5 manual muscle test equates to in relation to a non-paralytic normal on a maximal contraction? The answer is B, 53%. And so even less of a contraction than the hip extensors. And then we'll call this a 5 out of 5 MMT. It's a break test. So on a break test for the plantar flexors, what percentage do you think a 5 out of 5 would take compared to the maximal contraction of a non-paralytic normal? On this one, it's even worse. The answer is A, 18%. Now here's a chart that looks at how we actually test manual muscle testing for the ankle. And so we'll see that the percentage is better when it comes to knowing the percent versus an average normal on manual muscle testing. But it's still only about 80% of a maximal contraction. And so what we'll see is that manual muscle testing really is not able to identify the upper levels of normal strength. So from our last few slides, we were able to see that manual muscle testing isn't the most valid way to be able to capture underlying strength deficits because it just doesn't take that much force to get a 5 out of 5. But does this necessarily disqualify it from being a somewhat useful measure or somewhat useful screen for strength contributing to gait deviations? It probably wouldn't, because if somebody's not able to get a 5 out of 5 on a manual muscle test, then that would be suggestive of some pretty significant weakness, since it doesn't take that much to get a 5 out of 5 on manual muscle testing. And so that can actually make manual muscle testing a fairly decent screen when it comes to looking at weakness contributing to gait deviations. And so if weakness is contributing to gait deviations, we usually see that manifest during the phase of gait that places the highest demand on the weakened muscles. An example of this would be for the plantar flexors. And so review what stage of gait the plantar flexors have the highest demand. Hopefully you said terminal stance and didn't have to go look it up, but if you had to go look it up, that's okay. Just commit that to memory because it's important. Now, another point from this slide is that during the gait cycle, muscles usually function at what would equate to about a 3+ out of 5 MMT level when it comes to how hard they're contracting. The reason for that is that the muscles want to be able to leave adequate reserves to be able to avoid fatigue. And so they're only using about 25% of normal strength. And so if somebody only has a 3+ on manual muscle testing, then just to be able to go through one stride, that's their 1 rep max. And so more than likely, you're going to see their gait patterns start to break down pretty quickly. So an understanding of muscle activity during normal gait is going to be important when you're analyzing pathological gait, because based on where in the gait cycle you're seeing gait deviations, you might want to test specific muscle groups that come on really strongly during that phase of gait. And you won't have time to test through all of the different muscles of the lower extremity as well as everything else that could be contributing to this gait deviation. You want to be able to quickly hypothesize which muscles are likely weak based on the gait deviations that they're showing you. An understanding of torque demands can also help you with being able to understand which muscles are coming on during which phase of gait. So our muscles react in response to joint torques, which are created by the ground reaction force vectors. And so what you see in this picture is a ground reaction force vector and the internal moment that's created in response to that force vector. And so you're seeing the red arrows are the muscle activity that are happening. And so let's start here at initial contact. And so our ground reaction force vector comes posterior to the ankle. And so this line would be pushing the ankle into plantar flexion. So your dorsiflexors come on to help slow your initial contact into loading response to be able to help with that shock absorption. So then up the chain here, again, we have the ground reaction force vector that is in front of the joint line of the knee. And so it's pushing on the front of your tibia, trying to extend your knee this way. And so we have a flexor moment happening at the knee. And so we have an internal flexor moment created at the knee. And then up the chain, now our ground reaction force vector is anterior to the hip joint. So our line is pushing our thigh up towards our trunk, creating an external flexion moment. And so our extensors come on to fight that flexor moment to be able to stabilize the hip there. All right, so then similar thing for loading response. So we still have the ground reaction force vector behind the ankle, pushing us into plantar flexion. And so that creates a dorsiflexor internal moment. Our dorsiflexors are coming on. This time, with loading response, the ground reaction force vector is behind our knee, and so this line is trying to push our tibia up into our thigh, creating a flexor moment. And so our quads come on strongly to create an extensor moment to be able to fight that external flexor moment and create some nice shock absorption into loading response. And then our ground reaction force vector is still in front of the line of our hips, trying to push our thigh up towards our trunk, creating that external flexor moment. And so our extensors are still on to be able to fight that. So you guys compare these ground reaction force vectors with what you know about timing of muscles in the gait cycle, as well as your Rancho's book, to see if you can get a better understanding of ground reaction force vectors and timing of muscle contractions during gait. So now we're going to take a closer look at the controversy of the role of the plantar flexors. So there are three primary theories in the PT world. There's a controlled roll-off, an active push-off, or the acceleration of the leg into swing. Each one of these has different contentions about how we propel ourselves forward during gait and what exactly the role of the plantar flexors are. So if you look at EMG activities in your Rancho's Los Amigos book, the theory that makes the most sense is a controlled roll-off. So what we see is plantar flexor torque start to build up as the tibia moves through mid-stance into terminal stance. And the plantar flexors are eccentrically allowing that tibia to continue to move forward, but they're storing up a lot of force as they do. And then once we reach a critical moment where we're transitioning into pre-swing, the ankle rapidly plantar flexes, and then the EMG goes silent for the gastrocsoleus complex. So that would seem to suggest that a controlled roll-off where force is stored in eccentric contraction in the plantar flexors and then released to create our toe rocker as being the most viable theory. But the controversy is still out there. Either way, the plantar flexors play an incredibly important role in mid-stance and terminal stance. I'm going to have you guys answer these questions on a flip grid for me. And so what I want you guys to do is join our course flip grid by clicking the first link. And then you are going to answer these questions in the discussion that we're going to have on this link. So next we're going to touch on sensory impairments and how they can affect your gait. So sensory deficits are most often seen concomitantly with weakness, but they can also occur in isolation, particularly in people that have spinal cord injuries. And a lack of proprioception would prevent the patient from knowing the position of their hip, knee, ankle, or foot, and the amount of contact that they have with the ground. And so because of this, proprioceptive deficits can lead to exaggerated or excessive motion to be able to ensure that the limb is contacting the correct place or being able to clear. You'll also see them use other sensory systems to be able to compensate for the lack of proprioceptive feedback. Usually this is vision, and it manifests itself as the person just looking at the ground, seeing where their feet are being placed. Now, if they have a proprioceptive deficit and weakness, then they're going to have slower or absent substitution strategies, and we may have to give them external substitution strategies like an assistive device or potentially an orthotic. And so proprioceptive testing is crucial to the assessment of gait. And you should really only be grading somebody as having normal proprioception if they are consistently giving you correct and rapid results. They could also have perceptual deficits, and so they might have gross proprioception intact, but their higher level processing may be affected, and so that corresponds with your brain injury course. They can also have deficits with sensory orientation and balance impairments that can be a result of both issues with motor control and sensory deficits. So now we'll look at pain and how that can affect the gait cycle. So pain often occurs concomitantly with other things that can affect someone's gait, such as deformity or range of motion issues, but this tension on the tissue can cause musculoskeletal pain that can also result in changes in their walking. So because of how the body handles pain, this leaves us with two obstacles to effective walking. So the number one, we term deformity, but our body will change its natural resting posture as a result of pain or trauma. You'll see that we tend to go to an open pack position of the joint to decrease the amount of articular pressure on a painful joint. And so this has implications on how well we'll be able to progress through the gait cycle. Other than this, we can also have weakness associated with pain. The weakness can either be an acute kind of protective response, where our body will downregulate the strength of our muscle contractions because of the pain. But it can also cause chronic issues, such as reduced activity, that lead to muscle atrophy and weakness over time. Here we have a chart that looks at the position of certain joints and how it relates to the amount of pressure that's within the joint. And so in A, See that the ankle joint pressure is the least when the ankle is at 15 degrees of plantar flexion. And then knee joint pressure is the least when the knee is at about 30 degrees of flexion. So oftentimes patients will keep their joints within a limited range of motion to reduce the discomfort associated with increasing their intra-articular pressure. So when you think about all the different positions that all of the joints have to go through to be able to get through the gait cycle, as well as the need to be able to bear weight on all of these joints, you can probably see the potential barriers that pain can cause for gait. In this next chart, you can see that as pressure in a painful joint increases, the strength of the muscle associated with that joint will decrease. Then what we have here is that when the joint is anesthetized, we have fully restored quad function. And so that tells us that pain is in fact affecting the strength of the muscles that surround the joint, and that this is likely a feedback mechanism that's designed to protect the joint structures from destructive pressures. It just so happens to interfere with our walking. So now we'll talk about impaired motor control. So motor control usually isn't just affected in isolation. It usually has to do with an upper motor neuron or a lower motor neuron pathology. You remember upper motor neuron syndromes usually result in motor control deficits in addition to weakness, elevated muscle tone, and sensory dysfunction. You might see these in people with a traumatic brain injury, a stroke, MS, a spinal cord injury, even potentially Parkinson's disease. Versus your lower motor neuron syndromes that usually result in motor control deficits in addition to weakness, flaccidity, atrophy, fasciculation, and potentially sensory dysfunction. So we might see this with AIDP or CIDP, peripheral neuropathies, polio, and myasthenia gravis. We can also have combined upper motor neuron or lower motor neuron disorders. This would be ALS. So selective motor control refers to our ability to be able to fractionate our muscles, so to be able to move them independently of each other, and also to be able to adjust direction, intensity, timing, and duration of a certain muscle action. And so if you think about walking is really heavy on selective muscle control because we have so many different kinds of muscles creating a bunch of different contractions with lots of different demands throughout the whole gait cycle. And so if we lose selective muscle control, it's going to be really difficult to transition from one phase to the next. And so an example of how this could manifest during gait is that if you lose the ability to selectively turn on your dorsiflexors, then you might have issues with foot slap at loading response. Even if you have strong dorsiflexors, not having the ability to transition from a concentric contraction where we're trying to get the dorsiflexors ready for initial contact to an eccentric contraction where now our dorsiflexor's job is to eccentrically slow the foot as it makes its way to the ground, then that's going to result in a foot slap. This bullet on the emergence of primitive control mechanisms have to do with upper motor neuron processes, and these can really disrupt the fluidity of gait as well as how we transition through our different phases. So one thing that we may see is a locomotor synergy or a central pattern generator that may provide an alternative to voluntary muscle control, where we see an exchange of flexion synergies that activate the hip and knee flexors and the dorsiflexors, and extensor synergies that activate the hip extensors, knee extensors, and plantar flexors. But we can also see flexion and extension synergies independently of one another, and these can have negative impacts on gait. And so for extensor pattern synergies, they can result in big-time swing limb clearance issues. And for flexion synergies, it can result in big-time stance stability deficits. So you might see with postural reflexes that certain postures that you place limbs or the person into increase the amount of tone that they might experience in their lower limbs. And so an example of this might be if the knee goes straight, then we get an increase in all of the extensor tone. And so the plantar flexors and the hip extensors would then fire, and the person would go into an extensor synergy. You might be able to break this synergy by bringing their hip and knee into flexion to try and relax the extensors and turn on the flexors. And then one of the most common things that we see as disrupting gait are our stretch reflexes. And the intensity of our stretch reflexes can vary with the velocity of the stimulus. And so that we would term spasticity. So spasticity is a velocity-dependent stretch reflex. And this can really disrupt the ability of the muscles to be able to contract eccentrically during the stance phase. So oftentimes during gait, spasticity and contracture can present pretty similarly because they both restrict the range of motion that we're able to go into. And so if we have significant plantar flexor spasticity, then our progression during the stance phase is going to be limited, and we'll probably lose our ankle rocker and our forefoot rocker. If we have more of a flexor spasticity, like a hip flexor spasticity, then this is going to restrict progression through mid and terminal stance because that's where we'd be placing a stretch on the hips. And so that's going to limit our ability to be able to achieve a good trailing limb stance and heel rise when we get to terminal stance. If we had spasticity in the quadriceps, then during pre-swing, when the quad gets stretched quickly, the quads will probably come on and limit our swing limb advancement, and that's going to lead to a stiff-legged kind of gait. And finally, if we have hamstring spasticity, then that's going to limit us at terminal swing and affect our placement of our foot as we come to initial contact. And so the pattern you might be able to see here is that spasticity really affects us when we have a large range of motion demand or when we have a demand for eccentric control of a muscle. So we've made it through our 5 major issues that lead to pathological gait. Now might be another time to be able to take a break and look back over the things that we've talked about so far. So we've talked about some of the things that can contribute to pathologic gait. So now we'll look at the process of pathologic gait analysis. So analyzing gait, whether it's normal or pathologic, requires a lot of practice and repetition. And when you see something that seems to be off about somebody's gait, you want to compare it to normal gait. Whatever your process is for analyzing gait, you want it to be complete and systematic. And so when I say complete, at some point, you should be looking at what's happening with the head, the shoulders, the arms, the trunk, the pelvis, hips, knees, ankles, and feet. And it should be done in the sagittal and frontal planes primarily, but we can also notice issues in the transverse plane. And so my own personal approach to gait analysis switches between a global perspective where I'm just looking at the whole person's body, seeing kind of what sticks out to me, and more of that segmental approach where I start distally down at the ankle and I work my way up proximally. But your approach to gait analysis might be different, and that's okay. As long as you're able to identify major problems that interfere with the 3 functional phases of gait, so your weight acceptance, your single limb support, and your swing limb advancement, then it doesn't really matter what approach you use to actually analyzing pathological gait. But again, just make sure that it is complete and that it's systematic. Some people, particularly when they're first starting to analyze pathologic gait, like to use a tool that can really help guide them through a systematic and complete process. And I think that's great. I think that's a totally valid way to learn. And so if you guys are wanting to improve your gait analysis skills, then you might consider taking out one of these Rancho forums and just heading out into the community and watching people walk for a while. And see if you can note the major problems that prevent them from having ineffective weight acceptance, ineffective single limb support, or an effective swing limb advancement. And that really is what we're primarily concerned about in this course. If something in their gait looks a little bit off from normal gait, but it's not affecting their ability to complete one of these tasks, or it's not significantly impacting the efficiency of their gait, then I might note that in my head, but I'm not going to start planning to intervene for that issue with their gait, because functionally they're doing just fine. So the other considerations that we have with gait are the environment that they're in. You can see illustrated in the GIF that we have here the effect of a difficult environment on somebody's gait pattern. Competing attentional demands can also affect our gait pattern. Like, just try and walk as fast as you can over a set distance while keeping your head up, and then while looking at your phone, and see if your gait changes any. Different loads can also affect the way that we walk. And so if you have a heavy backpack and you're trying to make it to class, it's going to adjust the way that you're walking versus if you're walking completely unencumbered. And then speed demands as well. Like, our joint range of motion and torque demands at our muscles are going to be different depending on how fast we're going. So when you're analyzing pathologic gait, the first thing that you want to do is figure out what the problems are with their gait. And so you're going to do your observational gait analysis, and you're going to determine significant deviations for each functional task. So you're just identifying what the deviations are. You're considering how these deviations interfere with each functional task, and you're going to list out what the major problems are and which task they're interfering with. And so that's first, just figuring out what deviations am I seeing. So then next, you're going to identify the underlying impairments. So you're going to consider all the possible causes that could be contributing to a major issue at a phase of gait. You're going to determine likely causes by referring to torque demands and joint positions. And so if I see that someone's knee is doing something funky in terminal stance, then I might think it's potentially due to weakness because there's a large plantar flexor torque demand, but it could also be due to poor range of motion into dorsiflexion, or it could be due to impaired motor control or spasticity in the plantar flexors, due to that eccentric stretch as well as the range of motion demand that's happening at this phase of gait. And so I'm going to have to go through and I'm going to have to test muscle strength, dorsiflexion, range of motion, and spasticity. And we're going to narrow down the list of possible causes and determine the most likely cause based on the results of our testing. All right, so we haven't gotten into any kind of orthotic prescription yet, but I just want to use this as a low-stakes thought exercise for you guys. We have the case of somebody that came in with impaired swing limb clearance, and his doctor prescribed him a carbon fiber AFO to help maintain his ankle in neutral. That's all that this AFO will do, is just keep his ankle maintained in neutral. And when we analyze his gait, he walks the same with and without the AFO. I want you guys to complete this flip grid and just answer why you think that may be. So now we're going to come back to our video here, and I'd like for you guys to practice your gait analysis skills. So how are you starting? Are you starting with a global perspective? We know we can't see the head and trunk very much. We can see a little bit of the arms. Are you guys starting proximally, like up towards the hip? Or are you guys starting distally down at the ankle? And then what kinds of gait impairments do you guys see? Do any of them affect weight acceptance, single limb stance, or swing limb advancement? So we'll put this video on Blackboard so that way you guys have an opportunity to be able to continue to analyze this. But we're going to go ahead and continue on. So we looked at the Rancho's Los Amigos form, and that's more of a rigid structure, which can be helpful for learning. But you may not need all of that structure, particularly as you get practice and you improve in your gait analysis skills. Here is a grid that's much more simple, but you can still categorize major deviations into your stance phase and your swing phase deficits. And you can hypothesize what impairments might be contributing to those gait deviations and be able to test them out accordingly. And we're still primarily concerned with what issues are interfering with our functional phases of gait. So we started out by looking kind of at the trees of walking, and we're going to zoom out now and kind of see the forest by looking at our ICF model. And so if we're looking at walking as an activity goal, we're going to want to know the context of how it fits in their life. So we can see an example of maybe somebody that has had a stroke. Over at body structure or body functions and structure, we can see all of the things that may be impairing their ability to be able to walk. Decreased muscle strength, decreased motor control, decreased cardiovascular fitness, spasticity, and loss of sensation. We have different ways that we can capture walking as an activity. We can look at their speed, we can look at their endurance, see how they walk over various terrains or obstacles. We can use a functional outcome measure to be able to measure their walking ability. And depending on the outcome measure that we use, we might be able to put them into a category. Like the 10-meter walk test has a home level ambulator, a limited community level ambulator, and a unlimited community level ambulator based on how fast they walk. We could also use daily step counts to quantify the total amount of walking that they get in throughout the day. But always we want to see how do these walking activities enhance their participation in their life. With improved walking ability, are they able to get out of the house more and engage more in community reintegration, start doing some of the things that they had loved to do prior to their stroke, start socializing more, and have life be looking more normal compared with prior to their stroke. Then we always want to consider the contextual factors. While we're intervening with their walking, are they being safe? Or now are they having falls at home while they're practicing? Is this something that we need to intervene on and make them safe in the meantime while they're improving their function? And so interventions can include modifying their environment to make them more safe. Do we need to educate the family about decreasing the number of tripping obstacles that they have in their home, or improve the lighting for them if they have low vision? And then we need to look at the personal factors for the patient that we're dealing with specifically. And so does this person have the confidence to be able to practice walking? Or once they leave therapy, do they just start sitting? And inevitably, they're going to be prone to deconditioning? And how do we intervene to be able to improve their self-efficacy so that way they're not subject to increased fall risk? And then what is their readiness to change? And so this can certainly be affected by having a stroke, but it could also be a pre-stroke factor. Maybe somebody was very sedentary prior to their stroke, and they're not at the point where exercise is something important to them. These are the kinds of things that may affect our intervention decisions. And so regardless of our picture, we always have a focus on safety, trying to prevent secondary costly medical issues from arising, things like falls or deconditioning. But some of these contextual factors may limit how far we get with a certain patient. So we're going to touch on instrumented gait analysis here. There are a couple of tools that you could use for instrumented gait analysis, starting with some things that are pretty clinically available, just a stopwatch or a basic video camera that would allow you to be able to stop, rewatch the person's gait, and get some temporal and spatial data on exactly how it is that they're walking. So this has an advantage over observational gait analysis because observational gait analysis is limited in its ability to be able to quantify gait performance. We can see the quality of their walking, but we don't get as many quantitative measures. And so use of a stopwatch or a basic video camera is a nice way to be able to get some more quantitative information or data to be able to improve your clinical decision making and to be able to go back and evaluate after you've intervened to see, did my intervention have an effect? So then going up the pyramid here, you may see in some labs or specialty clinics electronic pressure sensitive walkways that gives a little bit more information about some of the spatial measures of gait. And again, it's useful data to be able to make clinical decisions off of. And finally, at the top of our pyramid here, motion analysis labs that you'll really only see in research labs. This is not something that is really clinically available due to how time-consuming it is, the technical demands, how expensive it is. And so while this can give us a lot of really cool data about spatial and temporal components of gait, if you're actually just treating someone in the clinic, it's not something that you really need. You can do with a lot less. But if any of you get into gait research, then you may be exposed to some motion analysis software like GaitRight or Protokinetics Xeno Walkway that can give you some cool information, but again, it may not ultimately change the patient's prognosis or the treatment interventions that you decide to do. But similar to a video camera and stopwatch, we also have other temporal and spatial measures that are more clinically available to us, and they give us valuable data about a patient's performance that we're able to track over time to be able to check the efficacy of our interventions. And so we can look at gait speed through the 10-meter walk test. We can measure their cadence by having them walk on a basic video camera and just counting the number of steps that they take per minute, or we can just count their steps as they're walking. We have endurance measures, the 2, 6, and 12-minute walk tests. We can check their gait symmetry in ways that are just as primitive as having them put some powder on their foot and having them walk and then measuring from one step to the next, or having them walk in sand if that's something that's safe for them. And then we have a couple of measures that look at a number of domains involved in walking. So for example, the timed up and go, it looks at your ability to go from a sitting position to a standing position, as well as a standing position to a sitting position. It looks at your gait speed, and it looks at your turning ability. And so knowledge of these measures is important because you'll have specific ideas about what you want to improve and what you want to intervene on, and you want your measure to be able to reflect the work that you've been putting in on helping the patient to be able to improve their function. So yeah, as we've been talking about, the instruments that you can use to be able to capture temporal and spatial measures of gait vary from being pretty primitive to being extremely technologically advanced. And depending on the setting that you're in, you may use one more versus the other, but the overall goals are to capture quantitative information on how a patient's walking and to be able to measure change over time. So we've talked a lot about temporal and spatial measures of gait, and those fall within the activity domain of the ICF model. But gait is also important for participation, and so it's good to be able to capture that by issuing participation and quality of life measures. And so many quality of life measures include items related to walking function because of the association of walking and improved quality of life. If you're able to get out and move around independently, then you're going to be able to pursue more of the things that you want to pursue that add to your overall quality of life. And so you may think about the aspects of gait that may limit somebody's access to be able to move about the community. So things like their walking speed, their walking endurance, and how these things can affect their overall quality of life, which makes it worth it to pursue improving their walking speed or their walking endurance as an intervention. Now, these aren't the only things that will determine whether somebody is able to get out into the community, meaning their walking speed and their walking endurance. There's a lot of other factors that can go into it. You may improve somebody's walking speed and walking endurance a lot to the point where on our objective tests, their walking speed and walking endurance wouldn't limit them from being a community ambulator. But the picture's bigger, which is why it necessitates the ICF model to be able to look at some more contextual factors. Are they aware of their environment? Do they have any kind of visual or processing issues that would keep them from being able to cross a street safely? Do they have some sensory processing issues where they're able to perform really well on level surfaces in our clinic, but then once we get them into more of a variable environmental context, the wheels fall off a little bit in terms of their walking ability? And so there are many determinants of community ambulation. And when you're out treating somebody in the clinic, when you get to the point that you're making decisions about whether somebody is a safe community ambulator, you may have to take them out into the community and just see how they operate. How do they do crossing streets, navigating crowds, avoiding obstacles, etc.? And then there's an association of gaitability with cost and caregiver burden. Somebody that is able to get up and move and walk around, they're going to be moving more, exercising more. They're going to be at less risk for secondary medical complications that come with immobility that can end up being costly to the healthcare system as a whole. And somebody that's independent with being able to get up, walk around, fulfill some of their own needs are going to require less of their caregiver's attention and time to be able to take care of. So in this next section, we're going to look at some shortcuts that you can think about when performing gait assessment. And then we are going to practice relating certain gait deviations to certain impairments. So what are the common gait impairments that we see in people that have neurologic issues? So we'll look at this by swing phase and by stance phase. So starting with swing phase, when weakness is the issue, we see a lot of issues with their flexors, which makes sense because your flexors are really having to be on during swing phase. We can also see some issues with their knee extensors, particularly during that terminal swing phase. If spasticity is the issue that's affecting swing, then it's most likely going to be extensor spasticity. It makes sense. If we have the plantar flexors kicking in, knee extensors kicking in, and hip extensors kicking in, we're going to have that stiff leg that's going to be difficult to perform swing limb advancement with. Decreased range of motion. The most common issue that we see is decreased dorsiflexion, and so that's going to affect your swing limb advancement because the person's not able to clear their foot through. And then decreased sensation, it's going to affect their timing as well as their foot placement as they start preparing for initial contact. So now we'll look at our stance phase. And so if weakness is the issue, Remember that weakness is typically exposed in the phases of gait that put the most demand on the weakened muscles, and so often we'll see issues with the plantar flexors, the hip abductors or adductors, or extensors, knee extensors, ankle everters or inverters, and so that's a pretty extensive list of all of the muscles that come on during the stance phase. But breaking it apart by where exactly in the stance phase are you seeing the issue can help you isolate down what muscles are likely weak if weakness is the contributing factor. Then spasticity. Again, we tend to see that extensor spasticity is common and interferes with gait. It's particularly common in the plantar flexors as we're moving through mid-stance and terminal stance. Decreased range of motion. Again, limited dorsiflexion is something that happens very commonly in people with neurologic issues. We might see issues at the same phases of gait that we're seeing issues with plantar flexor spasticity. And so commonly you are having to decide between, okay, I'm seeing this gait deviation. Is this due to decreased dorsiflexion range of motion, or is this due to plantar flexor spasticity potentially? And then again, same thing as swing phase, decreased sensation can interfere with timing, can interfere with placement, which can result in gait deviations throughout the stance phase cycle. So now we have 2 slides on gait deviations, potential causes, and consequences. And so I'm going to go through the first slide for you guys, and then I'm going to leave the second slide for you guys to be able to do on your own. And so if we look first at a lack of heel contact, potential causes of this could be excessive knee flexion and terminal swing, leading to a foot flat contact. It could be compensatory for weak quads, so we're going to avoid a normal loading response because the quads aren't able to handle the amount of torque that occurs at a normal loading response. They might have excessive plantar flexion in terminal swing, leading again to a foot flat contact, and so I would want to check dorsiflexion range of motion. They might also just be having heel pain. And so the consequences of this would be poor positioning for a heel rocker, and so we'll probably lose momentum, which will decrease our gait efficiency. And it's also going to decrease our shock absorption by limiting the amount of knee flexion that we get as we transition into loading response. So now we'll look at the knee being extended in loading response. So a potential cause of this could be, again, weak quads. We're locking out the knee, trying to avoid that loading response. This could go hand in hand with our initial contact, and so we might be having a forefoot or a foot flat contact because we have decreased dorsiflexion. The person might just be having knee pain and doesn't want the quads to come on to exacerbate that knee pain. And it could also be due to quad hypertonicity. As we went into pre-swing, we got a stretch to the quads that kicked in our quad spasticity, which stayed on throughout the swing phase, and we're not able to eccentrically control our quad to have an effective loading response. And so the consequence of this would be decreased shock absorption, impaired forward momentum of the tibia, which would decrease our gait efficiency, and potentially injury to the posterior capsule of the knee joint if left unchecked. So then lack of dorsiflexion in mid-stance and terminal stance. So this could be due to a plantar flexure contracture or plantar flexion spasticity. We've been talking about this kind of throughout this lecture. We might see it due to weak quads, although if this is the case, then we would expect that the knee would also be hyperextended at loading response, where the quads have their greatest demand in the gait cycle. Could also be due to impaired proprioception, and so the body doesn't have a good idea of where the knee is in space, and so it locks back onto bony stability, and we would see a hyperextended knee throughout the gait cycle. And it could also be due to ankle pain, where we're wanting to keep our ankle in that open pack position, and so we're not transitioning from plantar flexion into dorsiflexion. So the consequences of this would be, again, poor position for a heel rocker, which would decrease our gait efficiency and momentum because we lose that forward progression of the tibia over the ankle and the forefoot for our second and third rocker, or ankle and forefoot rocker. So then we'll look at an aberrant heel rise, and so our heel rise may happen too early in the gait cycle. And so this could be due to a hip flexion contracture, or it could be due to some anterior hip pain. Either way, we're not stretching the hip back into extension the way that we would need for a normal terminal stance. And so we leave the terminal stance phase early. And so this would decrease the step length on the opposite side. This would potentially increase the demand on the quads and the hip extensors because we're not getting into that locked out position towards terminal stance where we see the quads be able to turn off because we have passive stability at our knee joint. And so that decreases the efficiency of our gait. And that lack of achieving passive stability can also decrease our overall limb stability. The other thing that we might see is no heel rise at all, which can be due to a weak calf or excessive dorsiflexion range of motion, where we're not getting all of that eccentric energy stored as the calf holds back the tibia. Could also be due to ankle or metatarsal pain, where we're just not progressing far enough over our ankle to be able to achieve heel rise. It could also happen due to inadequate extension of the toes, where again our center of mass isn't translating forward enough to be able to achieve heel rise before we take a step with the contralateral limb. And so if we have an absent heel rise, that can interfere with the progression over our forefoot, which again would decrease the efficiency of our gait. We lose our third and fourth rocker there, and not being able to store up all of that eccentric force in our plantar flexors might then result in limited knee flexion as we're trying to perform swing limb advancement. And if you're not sure how the plantar flexors releasing that energy can contribute to knee flexion swing limb advancement, then head over to the flip grid that we had on the role of the plantar flexors and try and think about how all of that stored energy and then releasing it can contribute to knee flexion during swing. And another deviation that we might see is a stiff knee in swing. And this can be due to a lack of heel off and terminal stance because we don't get that knee flexion that we were just talking about. They might have impaired motor control, where it makes it more difficult to rapidly flex the knee as we transition into our swing phase. Could be due to knee pain, where they're just not wanting to flex the knee. They might have a knee extension contracture. They might have plantar flexor or quad spasticity that keeps them from being able to flex their knee. Or they might have weakness in their hamstrings that keeps them from being able to flex their knee as we go through like initial and mid-swing. Or they could have hip flexor weakness, where their rectus femoris needs to come in to be able to help them clear their leg through, which limits their swing limb advancement. And so any of these things would interfere with foot clearance during your initial swing and results in increased energy cost of gait overall. So then finally, if we're seeing excessive plantar flexion during swing phase, this could be due to weakness in your pretibials, could be due to a plantar flexor contracture, plantar flexor spasticity, or lack of selective dorsiflexor control. And the result of this is that it would interfere with foot clearance and interfere with foot position for initial contact. So I want you guys to be able to think through some potential causes and consequences to gait on this slide. There's also a tool for you on Blackboard to use. That's a self-review over pathologic gait. So you're going to do this on your own. There's going to be nothing to turn in. And if you understand these gait deviations, potential causes, and consequences to the gait cycle, then it's going to make the rest of the course much easier. So these are common deviations associated with gait at the activity level that look at gait from more of a temporal spatial kind of viewpoint, or a global functional kind of viewpoint. And so we have decreased velocity, asymmetrical step length, altered swing and stance time, increased base of support. So we might see their feet out wider than what would be normal. Swing and stance asymmetries. And so their swing time and their stance time might be normal on one leg, but then they might have like more stance time on the other leg. More of a global observation here that they're unable to alter their gait speed or pattern, which has implications for community ambulation. And then altered double or single limb support. So with function in mind, what is the sequela of altered gait? So we might see additional impairments that result due to immobility or altered gait patterns. We might see that because of weakness or poor range of motion or spasticity, that increased pressure and abnormal forces are put on different joints, and that can lead to musculoskeletal pain, or lack of mobility might lead to atrophy, increased weakness, etc. We've been talking a lot in the most recent slides about increased energy expenditure. So gait is a very efficient process, but it relies a lot on timing of muscle contractions and preserved momentum. And so when that's affected, gait becomes much more of an energy-consuming task. Obviously, with altered muscle timing, decreased overall balance, and potentially issues with just your limbs not being where you want them to be, this can lead to falls, which can have really significant medical consequences, especially for our older or neurologically impaired patients. We can also see activity and participation limitations and restrictions. So this is difficult for our people with neurologic issues because many of them already have significant issues with being able to perform the activities that they once did or participate in the things that make their life normal and fulfilling. And so these alterations in their gait can exacerbate those issues. And then the stigma and the psychosocial impact. So oftentimes we may hear that somebody is concerned that other people may think that they've had too much to drink because of the way that they're walking, or that everyone in a crowd is looking at them because their gait pattern is so different. And so this can present even an additional barrier towards getting out and participating in the activities that they once loved to participate in because of that anxiety of having people potentially looking at them or judging them. So we are in the home stretch of this presentation, but if you want to take one more break, now would be the time to do so, to be able to review what we've talked about so far in terms of gait analysis, instrumented gait analysis, and the overall effect of gait deviations on somebody's activity and participation. So the brain injury and a stroke, we'll see some common impairments, some of them more focal, some of them more global. And so we might see knee instability, impaired balance, impaired or absent sensation, decreased walking speed, increased walking expenditure, spasticity, and decreased selective motor control. And so while the presentation can vary, the issues that you see here over to the left are some of the things that happen the most commonly. People that have a stroke or a traumatic brain injury. And so on this person, we're going to be using him over the next couple of slides, but you'll be watching his left foot where his sock is a little bit longer. That's going to be his more impaired side. I want you guys to do some of your own gait analysis here. I'm sure you're already picking up on some things. Commonly at the ankle and foot for people that have a brain injury or stroke, during swing phase, we're going to see decreased swing limb advancement and an equinovarus posture where the ankle is plantar flexed and inverted, along with poor prepositioning for initial contact. And so then in the stance phase at the ankle and foot, commonly we'll see a foot flat or a forefoot contact, medial lateral ankle instability, a varus ankle, decreased pronation, a lack of dorsiflexion, and absent or impaired rockers. I'm going to back this up a little bit. And so see what you can see for this person's gait. You might notice some decreased dorsiflexion as he brings himself through swing. A little bit of a medial whip as he is trying to clear that left foot through. Limited heel contact. He might get a little bit of it down. It's mostly a foot flat contact, no real heel rocker, and a limited toe rocker. If we look at the sagittal plane here. So moving on to the knee. So common things that you see at the knee is instability, and so poor tibial control or quadriceps weakness, or because of quadriceps weakness. And so this can be due to plantar flexors or quadriceps sensation. A lot of different things can contribute to poor knee control. And you'll see some common compensations. And so you might have a forward trunk lean that places our center of mass in front of the knee. And so that creates an extension moment at the knee. We also might see knee hyperextension, which can be due to weak quadriceps. But again, as I stated earlier, then we would probably see that in our loading response where we have the max demand for the quadriceps. And so for people that have a stroke or a brain injury, usually if we see knee hyperextension, a lot of times it's happening a little bit later in the gait cycle at mid stance and terminal stance. And that can be due to weak plantar flexors, but it can also be due to decreased sensation or spasticity or impaired range of motion. So then looking at the hip and pelvis, some common things that you'll see again is a forward trunk lean to increase knee stability, which increases the energy cost of walking and step length because we're not getting that nice forward progression of the tibia that preserves all of our rockers. And pelvic retraction, so excessive external rotation of the pelvis throughout the stance phase, and so that decreases the amount of momentum that can be generated. We're not going to be able to get that nice terminal stance. It's also going to make hip flexion more difficult, so that can impair our swing limb advancement and decreases our overall step length, again, more so due to the issues with stance, not able to achieve that nice terminal stance. It's going to decrease our step length on the contralateral side. And so if we look at him here, we'll also see in the frontal plane that he gets kind of a hip drop on both sides. His left hip is adducting, again, that medial whip as he clears himself through. And we see his pelvic retraction in kind of late mid-stance to terminal stance on that left side where he's a bit excessively externally rotated. And that's going to cause some issues with his step length. And then for the head, arm, and trunk, commonly we'll see an excessive lateral trunk lean. We might see them just favoring over towards their stronger side, not wanting to put as much weight on their weak side. And we also might see them do that to be able to clear their limb during swing. So they might have to lean over, in this case, to the right to be able to clear that left foot through to have a good swing limb advancement. Again, we might see a forward trunk lean due to knee instability. And then we might see overall decreased arm swing due to decreased gait speed, lack of trunk and pelvic rotation, which tells us a little bit about their balance as well as the efficiency of their walking. And with our guy here, we see a little bit of a compensated Trendelenburg gait where he is actually leaning over his left side to decrease the moment arm on his hip abductors. And we definitely see a decreased left arm swing and decreased trunk rotation for this guy. So then with a diabetic neuropathy, we'll see deviations that are consistent with sensory loss, and so we're going to see them really widen out their base of support, trying to increase their stability. They're not really going to know where their limbs are in space, and so that can impair their swing limb clearance, as well as give us issues with stability during stance, because that makes it much more difficult to be able to time muscle contractions when you're not getting feedback about where your joints are in space. And their gait can also be painful, particularly in their feet. And so with this gentleman here, we see a wide base of support. His center of mass is excessively laterally displaced. Both of his hips are in external rotation, widening out that base of support even further. We see an increased arm swing with him and reduced trunk rotation. Limited pelvic rotation. Let me back it up a little bit so we can see the forward again. He leaves terminal stance kind of early. We don't see a good heel rise as he gets up into terminal stance. So he might be limiting his step length because he doesn't feel stable. And then we see circumduction for him to be able to clear his limb through. So then people with a spinal cord injury, it really is dependent on the level and the degree of incompleteness, whether they'll be able to walk at all and how they'll be walking. So often they have an asymmetrical presentation where one side is much stronger than the other, similar to hemiplegia in people with a stroke or a brain injury, as well as spasticity, which can be in either an extensor or a flexor pattern. But a lot of times we will see that extensor pattern, which interferes with both our stance and our swing phase of gait. Then we often see more weakness in the extensors versus the flexors. The extensors are usually innervated by lower segments in the spinal cord, and so we'll see a lot of weakness in those extensors. Now for this woman, we see that she has a 4-foot contact during weight acceptance. We kind of see a flexor synergy kicked in as she is performing swing limb advancement. See that her pelvis stays anteriorly rotated and she's limited in her step length bilaterally. At her ankles, both of her feet are inverted during swing and initial contact. So motor neuron diseases, these tend to be really variable in their gait presentation. First, you want to know, is this an upper motor neuron issue or is this a lower motor neuron issue? That'll tell you about the things that will probably interfere with the gait cycle, and it'll also tell you if you're seeing something other than what you expect, then that's certainly a red flag and something that you would need to pass on to the person's physician. So the other thing that we want to know is what is the person's prognosis or their disease sequela with their certain diagnosis? Because that will affect the decisions that we make in terms of our interventions on their gait, as well as our orthotic prescriptions. So if we look at somebody with Parkinson's disease, common things that we'll see is a narrow base of support, poor weight shift from side to side, decreased step lengths. You'll see an increased cadence, so faster stepping with decreased step length bilaterally. It's common that they will retropulse backwards, and they also have difficulty with transitions. And so, like going through a doorway, they'll have difficulty with that, and we may see them freeze. So multiple sclerosis. Again, It's a motor neuron disease and extremely variable in the structures that it affects, and so it'll be extremely variable in the gait presentation that we get. But more common things to see are knee instability, impaired balance, impaired sensation, decreased walking speed, increased energy expenditure, spasticity, or decreased selective motor control. And so, if this looks familiar, this was the same list as on our brain injury and stroke list, because MS is an upper motor neuron disease, and so a lot of times we'll see the same kinds of issues that we see with our folks that have a brain injury or a stroke. And so for this woman, her weight acceptance doesn't look terrible, maybe a little bit limited on that left in terms of her dorsiflexion range of motion. During single limb stance, she kind of leaves the stance phase early, and we also see a hyperextension at the knee. We'll see that a little bit more clearly when she turns around here. We can see pelvic retraction in mid to late stance phase. And we can also, it's a little bit hard to see because we're in the sagittal plane here, but we can see a little bit of hip drop right there. And then her ankle is inverting to be able to help her be able to clear through. And so that lends a little bit of credence to the issues that we saw earlier with her swing limb. So then we're going to revisit this video to talk about cerebral palsy. So oftentimes in these people, we'll see diminished heel contact because they get that crouched gait. We'll see hyperextension of the trunk where they are trying to keep their center of mass over their base of support because of how much they're crouching. And so we may see plantar flexed ankles because these kids or adults often present with a lot of spasticity. We also see scissoring because of that spasticity. But we also may see excessive dorsiflexion because of the crouching. And so in this kiddo, we see a crouched gait pattern, and we do see kind of excessive dorsiflexion as he's making his way through the stance phase. Foot flat contact. We have toe drag as he's trying to clear his swing limb. Increased pelvic rotation, particularly as he's trying to clear that left side. Trunk hyperextension, excessive lumbar lordosis, and excessive adduction and internal rotation as he's clearing that left swing limb through as well. I hope this lecture was helpful for you and that you'll be able to come away from this lecture with a plan to be able to create your own process for analyzing gait, and that you will be able to hypothesize about gait deviations while keeping in mind the 5 most common contributors to gait deviations, that being limited range of motion, weakness, decreased selective motor control, pain, and decreased sensation. We also got an idea of the different tools that you can use to be able to quantify your patient's gait in addition to the qualitative gait analysis that you're getting through observational gait analysis. So using things like outcome measures, video analysis, stopwatches to give you more information on how you can alter your patient's gait to improve their function. And now you should also have a good idea of certain impairments that we commonly see with certain diagnoses. Always remember that walking one step at a time is good walking. That goes the same with learning. And if you have any questions, as always, reach out on the discussion board.